My name is Aaron Levo. I'm the Vice President of Communications and Public Affairs. Having a slight camera issue today, so I look a little bit taller than I might normally, but we'll roll with it and keep things moving. We have a packed agenda today, so we'll get right to it. We'll have a chance for questions. As always, you can pose questions using the Q&A function, and our esteemed panel will try their best to provide answers throughout the course of the town hall, and you can review answers that have been posted inside that Q&A function. Hopefully we'll also have time for some celebrations at the end. So first off, I'd like to introduce Rob McIsaac, our President and CEO, to try and walk us through the agenda today and let us know where we're at. So Rob, over to you.
Yeah, thanks very much, Aaron, and thanks all for tuning in today. As Aaron said, I think we do have a packed agenda. We are trying our best to sort of keep people informed with pertinent, relevant, helpful information about the pandemic and our response to it. And you can see the various topics up on the screen that we're going to deal with today. I guess just by way of introduction, I'd say, well, we are in the thick of things now, and the pandemic is really stretching our health system unlike anything we've ever experienced before. You know, the thing we've been most worried about for a long, long time is upon us, and getting past it is going to require and is requiring an extraordinary effort by all of us. At the moment, our focus is on opening up capacity for critical care, and we are doing that really having regard to the whole of our enterprise. We're looking at every opportunity to ensure that we have not only the physical space to open more critical care beds, but also people with the right skills and expertise to care for our sickest patients. I want to say that nothing is exempt from this consideration. We are looking everywhere. As we open up this capacity, we will do everything we can to make sure that redeployed staff and physicians are supported as much as possible. I know that going from one area to another is often somewhat uncomfortable, and we will do everything we can to make it as comfortable as it can be. In accordance with provincial direction, we've been ramping down elective surgeries, and non-emergent, non-urgent activities more broadly. This is a key enabler in our efforts to free up necessary, needed capacity. You'll hear more about our progress on these things in the course of today's town hall. All of this effort is to ensure that our health system province-wide is optimized as much as possible to respond to this very significant third wave. At local, regional, and provincial levels, we are participating in daily check-ins with our hospital partners, trying to ensure that no one hospital is overwhelmed. But our neighbors to the east are particularly hard hit, and we've had to step up to support them by accepting more and more patients from out of region. There are certain hospitals which are really at risk of failure because of the incredible volumes that they're seeing. All of this effort comes with difficult decisions regarding our programs and services, and we know those will become more apparent in the days and weeks ahead. There is no doubt we are going to have to shutter some services in order to make this work. We will do our best to keep you apprised of these matters as we get to them. These decisions will be based on an ethical framework and will ensure fairness across programs to the greatest extent possible. Later next month, we'll also open the mobile health unit currently under construction across from the general. This temporary structure will be an outlet for regional hospitals so that critical care beds can be preserved for patients with the most intense needs. Updates about the progress of the MHU will again be shared at these town halls and of course on our website. I know that the next couple of months will be hard on our patients and their families, and of course all of us. I can't overstate how essential it is that you sign up to get the vaccine if you haven't done so as soon as possible. Details are on our website for all staff and physicians. And when you're not at home, please follow all public health measures and wear essential PPE at all times while at work. We've all had more than enough of this thing. I know that. But we will get through so much better if we work together as a team. That means having the back of your coworkers and everyone else working here at Hamilton Health Sciences. It means taking care of each other. It means joining together in common cause to get through this for the good of our patients and for our community. So as always, I want to say thank you to everybody for joining in this common cause and fighting this good fight. Erin, I will pass it back over to you. Thank you all.
Okay, so I've seemed to have reconciled the height of my camera, but not the look. Anyways, we'll see how it goes throughout the webinar. Each time I pop up, it'll be a surprise. I'd like to invite Sharon Pearson, our EVP of Clinical Operations and Chief Operating Officer now to give us an update on where we're at across all of our sites and services. Sharon, over to you.
Thank you, Aaron, and good morning, everyone. It is good today that we've dedicated a lot of the agenda to talk about the operations at HHS, and you'll hear from Les Gauthier and Dr. Kelly, Bruce Squires, Les Gillies, in relation to various areas of operations across our sites. As Rob has said, we really are in the thick of things right now, and I know everyone is feeling the situation that we're in. In terms of the activity that has been ongoing, we've talked about this at every week. Town hall is the capacity conversations that happen with the province and the region. And those conversations have only escalated in the last week as we look at optimizing hospital resources across the regions. And as Rob indicated, the East is feeling those extreme pressures, and we are doing our best in the Ontario West region to support the population to the East. We did receive several orders this week from the province, one last week related to the surgical ramp down, and Dr. Kelly and Les Gillies are going to provide, or Les Gauthier rather, will provide the details related to the ramp down activity, but essentially we will and are only doing urgent and time sensitive care. With respect to the other two directives, one's related to consent and the other related to health human resources. In relation to consent, the new order allows hospitals to transfer patients without obtaining consent. Now, clearly, this would require a lot of thought and consideration and is only to be done in extreme situations. But should the need arise, there is an ability for hospitals to do that. It has been extremely difficult for the Ontario East region to manage some of the situations related to transfers. This was put in this order to enable the transfer process. We are working on supports and tools to support the teams with the communications with patients and families should we need to enact this as well. The second order relates to health human resources and external to us, and specifically to Ontario Health and home and community care supports. And what the legislation does is enable those staff to be directed to hospitals. I think everyone's very aware this is a very overwhelmed system and sector who has been struggling with their own capacity demands and recruitment challenges throughout COVID. I wouldn't say we would never see it happen, but I think it would be an extreme situation here in Hamilton before we saw those supports within our hospital, but we do have an enabling legislative order now that would support that. If we go to the next slide, in terms of our current situation, we have 75 COVID patients. It's a bit lower than the modeling would suggest right now. The 26 in ICU is more in keeping with what the modeling suggests we would have at this date, if not a little bit higher. Our occupancy rates, as you can see, are quite aligned with what we're seeing across the region. I would note, someone asked me about the occupancy numbers. Often this is captured at midnight census. So we don't always see that full occupancy rate there, but I know if we talk to any of the critical care areas, certainly everyone's feeling that like they're at 100%, which they are. In terms of the activity that we've been working with the regions on, there have been 91 out of region patients. The majority of patients have actually gone to Joseph Brant because of some of the capacity they've been able to offer. Here at HHS, we've received 24 of those patients. And we continue to support the case by case, particularly for some of those critical care transfers related to our regional programs, including our ECMO program that we have here at the Hamilton General. If we go to the next slide. In terms of what we're doing in response to those pressures, we have opened additional critical care capacity. To date, we've opened 12 new ICU beds between the Juravinski and the General, and we're planning for 18 more in the upcoming week. We've talked about the reduction in scheduled care. The other thing we are doing is home and community care with the support of Ontario Health has been working with long-term care to expand their capacity. Now we know we saw a reduction related to moving to 1 and 2 bedrooms, but there has been a reduction in admissions and some overall lower vacancies in long-term care throughout wave 1 and 2. So the long-term care sector have been asked to reopen some of that capacity, and we have seen the impact of that here at HHS and seen a number of long-term care transfers. We are working with our local teams, our local home and community care case managers at HHS to really ensure we are up to date with all of our files on our patients so that we are able to access these beds as they're made available. We are also maximizing our satellite health facility capacity. So we have had the 2 floors of 60. We have opened our last floor of 30, and we're doing the best we can to match patients from our acute sites to move to the satellite health facility. Leslie's going to touch on the deployment process we have in place to support all of this extra capacity that we have opened across our sites. We do have a number of other strategies underway that we will be moving forward with over the course of the next few days. And I'll update on those at the town hall next week. If we go to the next slide. And then lastly, as Rob mentioned, our mobile health unit, we have been asked to move forward with that. The mobile health unit is provided by Weatherhaven, is the vendor. It's one of 2 health units that will be erected in the province. The other is in Sunnybrook, and I understand there was some recent media around that today. And they should be opening their mobile health unit next week. It is a fully self-sufficient unit. Up to 80 patients can be accommodated in the unit. And it is self-sufficient in the sense of water, waste, energy, etc. It does support COVID and non-COVID population, and we are planning for those populations right now. Looking at patients with a length of stay that's on the lower range of 3 to 5 days, no critical care patients, and we are not intending to put ALC patients in the MHU either. It will be a provincial resource, as Rob indicated, so we will work with our partners across the region as far as accessing the MHU as well as staffing the MHU. And again, I will update more on the unit next week. There's a nice visual provided by Kelly Campbell, and her team is leading Nobleman's share of this work as we get the work moving forward. Also, a large operational team planning for occupancy. And I will be happy to answer questions later and hand it back to Aaron.
Thanks very much, Sharon. Next up, we have an update on our ongoing surgical ramp down and procedural impacts as well, thinking about the provincial direction that we've been provided. Our Surgeon in Chief, Dr. Stephen Kelly, is going to give us an update on that work underway. So Stephen, over to you.
Thanks, Aaron. So when we had that order on the Thursday night, Friday morning, the HHS Procedural Task Force met on the Friday, and there was a lot of work, as people know, a lot of work done last year to actually create an ethical framework for how we would classify procedural activity. And basically it's a 1 to 7, that framework. And what we are doing, we're going ahead with classes 1, 2, and 3A. So across all of our procedures, both ORs and endoscopy, HIU, etc., we are looking at reducing activity to make sure we can maintain that those 1, 2, and 3A activities. So we are ramping down in that systematic and ethical manner. We have cut the adult surgical capacity at the Hamilton General and Juravinski by 35%. We have reduced adult activity at the Mumsy site by 25%, but the order from the province was quite specific that pediatric activity should continue. And then we've also reduced activity in the endoscopy, the HIU, and the arrhythmia procedures by 50%. Next slide, please. We're continuing to provide our care for pediatrics, for the cancer work at the Juravinski, and all our regional programs at the Hamilton General, so neurosurgery, cardiac, vascular, spine, burns, etc. And obviously where things are clinically urgent, we will continue to provide that care. Obviously the ORs continue to provide the emergent and urgent surgeries, and there's been no change in scheduled care in the diagnostic areas or interventional radiology, because again, the province felt that these activities needed to continue to ensure that we could safely look after our patients. So that's all I have. I'll hand back to you, Erin.
Thanks very much, Dr. Kelly. Next up, I think we have Bruce Squires, our VP Women's and Children's Health, to give us an update on concurrently the work underway around our ambulatory services in a similar vein. Bruce, over to you.
Thanks very much, Aaron. Good morning, everyone. So since the start of the pandemic, there's been a task force co-chaired by Dr. Barry Lum, which has been meeting to guide the adaptation of our ambulatory care services in order to support the best care for all continuing, including in particular through virtual care. So that group has also recognized that we could face a situation where we might need to further adjust that care, not indiscriminately, but really because it was required in order to facilitate capacity or capability elsewhere in our system. So on that basis, the framework that you see before you was developed using a similar prioritization, ethical prioritization framework as was just referenced by Dr. Kelly. So we're now at the place where we are using this framework to evaluate how we will adjust ambulatory services in order to free up what right now is the most needed resource, health human resources for our critical care and also for ward care. So if I can turn to the next slide, this means that really as we make adjustments to ambulatory services across the organization using that framework, we're doing it where it assists in meeting our health human resource needs, always with a balance to how can we support continuation of care through virtual care, and what are the impacts on any care that cannot continue on the health and really well-being of our patients and their families. So as these decisions are made about which are the, where do we need to ramp down in order to free up HHR, and how does, how will that then be implemented, we'll communicate that information out directly to the teams. In the meantime, the message to patients and families is really that ambulatory visits and care needs to continue and will continue, and they should only react if they should find a communication from their provider telling them of a delay, a cancellation, or a change to virtual care. So those we've, through Dr. Kelly and myself, I think described the approach to procedural care as well as ambulatory care. I'll turn it back to you now, Aaron, to I think go to Leslie, who will tie it all together.
Yeah, good stuff. Thanks, Bruce. Yeah, Leslie Gillies is our next presenter, our interim VP of Community Medicine and Population Health. Leslie, I know there's been a ton of work done around this area getting ready for this moment. Can you walk us through what the redeployment process looks like and what people can expect?
Thank you, Aaron. Absolutely. So on behalf of Dr. Mohammed Panchu and myself as the Transition Task Force co-chairs, very pleased to be able to give a bit of an update of work to date. So we start with a thank you. We thank you for everyone taking on a new role, in the sense of, obviously there will be folks that are specifically deployed, to support the opening of the critical care beds as soon as possible. We're going to be working through those next steps. But also people take on a new role as new team members join. So again, the folks that are going to be deployed and working in a different setting, people are going to be very well supported, as well as the folks that are welcoming them to their units and so on. So thank you for everyone's support and collaboration, because absolutely that's a essential ingredient to support our patient care. So if we think about maybe a few months' time, there was certainly a need in the community. Most recently, again, Hamilton Health Science came and supported Grace Villa. And so when we're looking at deployment in that circumstance into the community versus more recently, now our own internal needs of deployment, what we've tried to do is really have great lessons learned. These are sort of unknown or unprecedented situations for all of us. And we're really trying to rapidly take some of the good lessons learned from the Grace Villa experience and apply into the internal deployment here that's most recently required. So please rest assured that in all of our planning processes, we have been following an ethical framework and really trying to have very clear principles of fairness and equity and transparency, and to include everyone that's will be impacted in this planning process. So much more to come. Very specific educational and resilience supports are in place, already in place, and will continue to be sort of on a 7-day a week model, recognizing that we want to make this supported as much as possible for the staff going into these new settings, but also for the staff who are welcoming their colleagues coming in as well. So we've got a lot of great information and tools available on the SharePoint sites, and we want to make sure that people are aware of them and have access to that as we move forward. Next slide, please. So as Sharon has alluded to, we're adding new ICU bed complement at both the JH and HGH sites. Obviously, staffing is required for that. We all recognize that there are significant staffing challenges at times, both within the critical care settings and the wards. So we've tried to incorporate that obviously in our planning to provide the necessary supports to open these beds incrementally as we have the available staffing. The reality is the patients are coming, so we're with folks trying to move as quickly but as safely as possible. We've had some staff already starting from the perioperative and procedural care areas, and we're very grateful for their support, ambulatory care, women's health, ICU, et cetera. So it's an all hands on deck approach. We certainly will have more areas involved as well, and more information to come along those lines. So again, just as much as we can on a daily basis, trying to best align folks' skill sets and competencies that they're coming with, so that it aligns as best as possible with the required staffing demands. As you can imagine, there's a lot of complexity to that, but please be assured that this is all of our focus in our planning. So we say direct your questions to your leaders because we know that we have relationships between the staff and their direct managers and directors and so on, but please know that everyone is here available to you. There's no wrong question that people can ask, and we want to make this as supported as possible and as successful as possible as well. So thank you to everyone, and thank you for your wonderful care of your patients, and more to come. Thanks, Erin.
Thanks very much, Leslie. Next up, I'm going to ask our Medical Director of Infection Prevention and Control, Dr. Dominic Mertz, to give us an update on the pandemic's epidemiology. Dominic, where are we at this week? What's the news?
Yeah, thanks, Aaron. I was told to be quick today, given that we have so many things on the agenda today. So I will focus on the Hamilton specific issues. So here you see the map as you're used to. We are at 180 above the Canadian average at this point, with cases continuing to increase. Next slide. This is the provincial view in terms of case numbers. You see the black line. I expect us to end up somewhere up here by the end of the week. So certainly more cases this week than last week. The hope really is that what we currently see is the Easter peak and that things will improve after that. Let's wait and see whether that's going to happen or not. In terms of hospital admissions here, again, the provincial picture first. You can see we are pretty much where we had been during peak one. Next slide. This is the Ontario-wide modeling, how we compare to the models, and you can see that compared to the vaccinating plus 4 week stay-at-home order, we are actually doing worse than expected. So while in the past, the models tended to be too pessimistic, I would say this one seems to be too optimistic, and I'm not sure whether we will get a new one today based on the latest developments. Next slide. The ICU modeling has been quite accurate. As you know, we are sitting in the province around those 600, which were predicted for this current situation where we are at 2 weeks after this modeling came out. Now the question will be how that will continue, but certainly we expect a further increase at this point of time. Next slide. That's the Hamilton epi curve, as you can see, and I mentioned last week, it looks very similar to what we've seen in wave 2. We had a plateau or even a drop during the holidays, this time around Easter the same. And then we probably see to a large extent an Easter holiday effect here. So again, the hope is that we will be going down, and that's what the local models will show that I show you later. Next slide. I've already shown that. Let's move on. So this is the forecast for the city of Hamilton, the gray line being the current predictions, where you see we will continue to increase and have a relatively wide peak by end of May. That's the most plausible scenario at this point of time, while the red line was the expectation based on the data last week. So this means we've seen more transmissions than expected in the week prior, probably triggered by the Easter holidays here. But now with the stay-at-home order and going online with schools, we expect that the peak will not be as high. And as you can see, similar to what we've seen back in wave 2, but a wider peak. So it will take longer to come down than it did back in January. Next slide. This is the comparison in terms of predicted number of cases. As mentioned earlier, we are expecting more cases, but probably less hospital admissions within Hamilton. We had 8,800 in wave 2. We expect around 13,000 in wave 3 in cases in Hamilton, and staying in online learning will affect this by 637 cases. That's the prediction. I think you can make up your own mind whether this justifies keeping schools closed until end of June or not. Next slide. This is the hospital admission forecast and probably the most important piece for us, but it comes with a very important caveat. This is for Hamiltonians. Now, A, we support the region, B, we support the province. So despite the fact that it looks like based on these predictions here that we will not see a further increase in total admissions of Hamiltonians in the weeks to come, we will probably still see an increase because many of the regions around us are seeing a steeper increase in case numbers than we do currently, and their epi curves will likely look much different. Plus, the weight balancing or load balancing within the province, with in particular ICU patients coming in from the GTA to continue. So with all of this in mind, we will probably continue to see an increase in admitted patients, but not necessarily Hamiltonians. Next slide. VOCs, it seems to kind of level off at around 70% of all the positive cases being VOCs, keeping in mind that we are always several days behind. Hamilton is currently at 65%, so as predicted, caught up with the rest of the province and now seems to be leveling off as well in terms of further increase. Next slide. Again, across the province, mostly B117s. They also now added below the mutations because, as you know, for most we would only have data on mutations and not necessarily the sequencing. Still 176 P1 at this point, and even less so B1351, so the South African variant. Next slide. Now, Hamilton has identified the first two P1s yesterday, and today the first B1351 was added to the list. So we now have all the three variants of concerns identified in Hamilton as well. Next slide. Thanks, handing it back to you, Aaron.
Okay, great. Thanks, Dominic. That concludes our presentations for today. So we'll move to our Q&A session. Please, a reminder, use the Q&A function, not the chat. Use the Q&A function to pose questions. We'll type and respond to answers. You can also raise your hand in the attendees forum in order to ask a question. I see one hand raised from MNB. We'll get to that in a minute, just in case the hand was raised in error, which I know has happened in the past. And a second from Barbara. See, Barbara's canceled hers. So we'll just wait and see if those questions stand, and we'll go to the Q&A box first. Maybe I could ask a question. I know just around Leslie Gillies, your presentation did highlight that the procedural, surgical, and ambulatory ramp down will be a primary driver of staffing for our new critical care beds. I mean, we've managed to get to a point where we're staffing them. I know there's active discussions underway about other strategies. When can people expect to hear more?
Thanks, Aaron. Yes, we'll be meeting sort of with the teams directly in the next day or two. There was a question I saw on the Q&A, will EPIC be impacted in any way? Yes, we are looking at all resources. I don't think there's many areas, both inpatient, ambulatory initiatives, very important initiatives like Odyssey underway. So we're going to try and minimize, obviously, impact, but we'll be tapping into some of those resources for sure. So, yeah.
Okay, thanks for that. Another question that came up, maybe Bruce, this one's best suited for you, but is the idea that, you know, if people are being redeployed into settings, can their vaccination, their second dose be expedited? Like as it stands, I think we're still holding firm with the provincial direction, are we not?
Yeah, the provincial direction has been quite clear, despite it being raised very frequently by both hospital leaders and public health leaders from across the province, including our own. And that direction from the province is that there are only a very small number of health condition-based exemptions, plus with our Indigenous population, to that extended second dose interval. So certainly recognize that poses a level of concern for many of our individuals. Our leaders have certainly talked to us, our experts in internationally, nationally, and locally about the very significant levels of protection that are provided by the first dose, particularly after a couple of weeks after vaccination. But nonetheless, we recognize that it's a source of additional anxiety for individuals, and so you know, we'll continue to raise it. We're also, as our president has noted in the chat, I think continues to be important that professional associations of many of our teams at a provincial level also continue to raise that issue of concern.
Great, thanks very much, Bruce. I'm going to go to our live questions. The MNB, you still have your hand up, so I'm going to hit going to allow you to ask your question. You'll get an unmute request, and you can do that and ask your question. Go ahead. Try this one more time. MNB, you can go ahead and ask your question if you can. No. Okay, so we'll move to the next one. I see Sean Wharton with a hand up. Sean, you can go ahead and ask your question if you want to go. Okay. We'll try that again in a minute if we can, Sean. We'll get to you again in a second. Going back to our Q&A, we have a question here about the impact on the trauma program, I guess maybe in relation to the ramp down that's underway. I know, Sharon, perhaps maybe if you could give us some insight on programs that, our critical regional program that we're sustaining.
We are, yeah. And the answer is just that. We're sustaining access to our regional programs, and we continue, as Stephen indicated, provide our time-sensitive urgent care.
It's also a question here about our visitation policy and whether or not we reevaluate the visitation policy as we proceed to see a rising number of cases in the community. Any insight on that?
For sure. I mean, I'm not sure if Kirsten's on the call and wants to jump into that, but we would always be reevaluating, and that's a constant conversation at the SME table, and when we would make a decision to make changes.
Yeah, Kirsten's with us too. Kirsten, what do you have to add to that?
Yeah, just we actually did have a purposeful discussion around visitors last week at the subject matter expert team, which is a regional expert team. So no change at this point in time. The benefits of our essential caregivers with our patients still absolutely outweighs as far as benefits rather than closing it down. But of course, if we need to readdress it, we will continue to do so. But certainly we're not getting any other evidence that visitors at this stage of the game are any more at risk or providing or creating any additional risk to the organization. So for now, it's status quo. Thank you.
Great, thanks. Leslie Gillies, there's a question in here about redeployment and how consideration might be given to workers. Like, how do you balance the things, the personal circumstances of individual workers, perhaps young children or other factors as we move into this redeployment discussion?
Thanks, Aaron. Well, I guess it would be no different than what we need to be doing currently in our respective sort of clinical areas, be it inpatient or outpatient or project related. So we'll be working closely with the staff to facilitate it as seamlessly as possible. We recognize whether people are being deployed or even in their current circumstances with all the changes that are happening with the schools and kids being back at home and so on. We'll work as closely with people as possible in alignment with their management supervisors or managers that they directly work with on a day-to-day basis. So it'll be a very collaborative effort between the CSO and the task force and the units or areas that they're coming from.
And are we accepting volunteers too? Are people putting their hand up to step forward for this redeployment at this time?
100%. It's very exciting. We've got some folks that have already come forward and expressed interest. So there's a number of different places that people can be coming from a volunteer perspective. We've had a few people already sort of come back from retirement and express interest in coming back into the critical care setting, which is exciting. We've had some volunteers that come from other areas. And so we're going to work really closely to integrate all of those offers that come forward so that we can best match our critical care resource in staffing to the patient care needs. So it'll be a daily process, but we're very, very open and looking to welcome our volunteers in. Good
stuff. Thank you. Bruce Squires, there's a question here about the use of virtual care for our services, specifically at the Ron Joyce Children's Health Center. Can you shed some light on what we might already be doing for services at that place and what might be occurring in the weeks ahead?
Yeah, absolutely, Aaron, and it really is consistent with our continued message. Virtual care has been, in many cases, wonderful for the children and the families that are treated at the Ron Joyce Center, particularly in our outpatient mental health, autism, developmental pediatrics, and rehab programs. So where we stand now, again, and we already spoke to this a little bit around visitation policies, where it continues to be in the best interests of these patients and families to receive some in-person care. We're going to continue that until such time as there's a reason or a need to stop that for either their safety or that of our teams. Yeah, no, at this point, no immediate plans to change the approach that's been taken now, but always under consideration.
And as we think about our overall outpatient volumes, there's a question here, perhaps alluding to the fact that outpatient volumes are still rising. Like, what are we seeing broadly? Are there specific pockets of increased care, or what could you say to that?
Yeah, thanks, Aaron. I mean, the data is not suggesting an overall rise. In fact, our volumes have remained fairly steady over the last few months in terms of the amount that's being done virtually and the amount that's being done in person. Again, as we consider the ramp down of some ambulatory services, we're really focusing on doing that where it generates additional capacity to support our critical care and inpatient services. We don't want to do that otherwise, where it doesn't generate that help, because we know that delaying care has a long-term and sometimes short-term impact on our patients and families, and may generate additional volumes in our emergency departments or otherwise. So the strategy in ambulatory care is really to look to only take action where it helps our challenges in critical care and inpatient care.
Understood. Thanks for that. Dr. Mertz, there's a question here about whether or not we're seeing any evidence about, those that have been vaccinated 1 or 2 shots, are people that have been vaccinated still showing up with COVID?
It's that I'm not aware that anyone at HHS would currently have the bandwidth to systematically collect and look at. Public health would have that data. They know who's testing positive. They would know who had one or 2 vaccines received. I think what I can tell you from an outbreak perspective, when we ask that question, who of those patients has had the vaccine at St. Peter's, where everyone pretty much, well, most of the patients were qualified for the vaccine already. We did have some patients who have had the vaccine, typically very close to the vaccine. And at least in the beginning, I didn't follow up on that. Those were the asymptomatic individuals. What I can certainly say, and I presented that data previously from long-term care, what we see in long-term care is very different from wave 2. So the vaccines do work. We cannot conclude from that if we had vaccinated every resident there with only the 1 shot, whether we would see the same effect. But also, if you look at who's affected by COVID now and who gets admitted with a shift to younger age groups, to a large extent, that's most likely driven by the vaccine. And many of those community-based older people would have had only 1 shot as well. So I think everyone points towards, yes, it does protect. I don't have data to compare 2 versus 1.
Yeah. Okay. Thank you nonetheless for providing the answer. There is a question here. Maybe I can ask Dr. Lum, Barry Lum, I think has joined us today. There's a question about the potential impact of pausing our EPIC installation. I know Leslie Gillies had mentioned that all ideas are on the table. I know there's active discussions underway. I guess the question I'd like to pose is, could you comment a bit on the needs to continue that work and keep our that in line of sight, given the impact on patient safety? If Barry's not with us, then perhaps I could call on Dave McKeag. I know Dave's also got intimately familiar with this topic over the course of the pandemic.
Yeah, can you hear me?
Yeah, we can hear you. Sure. Thanks, Barry.
So thanks for the question. Clearly, we want to continue the effort to make the Odyssey project successful and on time. That being said, we also clearly understand the impact on the organization and the need for redeployment. So we are literally meeting several times a day over the last few days to look at the various strategies that could be brought to bear to keep us on time and to get us to the go live. We all know that it's critical for the long-term success of the organization that we get this in place as soon as we can. Specifics, I think, will take a bit of time, just like it's going to take for all of the other redeployment conversations.
Gotcha. Thanks for the answer. I have another question here about visitation. Kirsten, you might wish to comment. Bruce, you might as well, specifically about having, given that we have all three variants of concern in the community, can we revisit the issue of having a husband or support person accompany a patient receiving an obstetrical ultrasound? I know there's been discussions. Oh, I see Leslie Gauthier has jumped on it ahead of both of you. So take that. Leslie, over to you.
Yeah, thank you. I'm really glad I get to answer this question. There's been considerable conversation on this issue, including our infectious disease physicians, our IPAC team, patient experience, our obstetrical leaders, and the team is very committed to continuing to allow that support person for the last 10 minutes of the ultrasound. I remind everyone on the ultrasound team, and we've had lots of really, really good conversation with the team around the PPE that is available for them, eye protection, the extended face shields, which was actually developed in collaboration with the ultrasound team. Patients, staff, physicians, caregivers are all screened at the doorway and universally masked, appreciating patients could be an exception to that. So we're very confident right now that that's a safe model of care. I would defer to Dominic just in terms of the conversation around risk. But right now we are still very much in support of the practice, and we have revisited the conversation as recently as Kirsten alluded to as of yesterday.
Yeah, thanks, Leslie. I don't think I have an awful lot to add. We looked at the risk. We are looking at a very short interaction with a masked individual who probably has the same risk of being positive as the patient in front of ultrasound tech that they spent up to an hour with. So we don't feel that it adds significant risk. And as such, weighing all the pros and cons that the current situation shouldn't change our decisions in the past, that it's an appropriate approach to use and allow them to come in for the last 10 minutes of an ultrasound.
Gotcha, thanks for that. There is a question here too, Bruce or Leslie might be able to answer, just around some individuals from the COVID unit who have recently registered for vaccination and haven't received a call back as of yet. Is it fair to say that those frontline workers are still prioritized as they were some time ago in the process?
Yes, it is absolutely, Aaron. And I think in this case, I would ask those individuals to go ahead and if they want to forward their name to their manager, who can forward along directly to myself or to the clinic, or if the individuals can get my name and forward it directly. We're at a position with folks who haven't had their first dose yet to make sure that they're getting that opportunity.
Okay, perfect. Thanks for that. I know there's still questions in our inbox here. I see questions about pandemic pay, vaccine tool, a number of things. I know there's also a couple of people typing answers diligently as we speak, but I do want to leave time for celebrations. I'm conscious as well that we want to end on time because everyone's got a ton of work to do right now. So maybe I could invite Rob McIsaac to join me back on screen, and we'll start our celebrations portion. I think I saw one come up already in here.
Yeah, so it's National Medical Laboratory Week. So I want to give a big shout out to everybody working in the lab. I think we have so much we can be proud of in terms of what's been accomplished in the lab over the last year and more. in response to the pandemic. So awesome work by our lab, which is really, in many respects, provincial, even national leader in the work they've been doing. So congratulations.
Good stuff. So just a reminder to everybody that you can raise your hand and we'll call on you to give your shout out live. You can also type something in the chat forum and have Rob or I read it out for everybody. I saw Leslie Gillies with a hand up there for a moment. Leslie, did you want to give a shout out?
Yes, thanks, Aaron. I just wanted to sincerely thank all the folks that have intensively participated on the transition task force to get all those materials ready and preparation, but also more recently, the critical care planning committee. We've had great representation from all of the respective clinical units, the ICUs and so on, practice, education, ethics, co-led by Nate Vanendel and Pam Westover. So lots of work to do, but thanks for that work to date.
Awesome, thanks. Bruce, I see you on camera. Is that just a legacy from your answering questions, or did you have a shout out to give as well?
That was a legacy from me answering questions, but I was typing a celebration, so I'll say it really quickly. I'd like to shout out the individuals and the teams working in the women's health ICU and the pediatric ICU who have both have had individuals go forward for redeployment and then have stepped back to adapt their coverage to support care in those areas. And of course, that just echoes to all of the other individuals across the entire organization who are, some of whom are redeploying and some of whom are stepping in their existing roles and taking on additional responsibility at a tough time. So just a big celebration and thank you to all.
Good.
Aaron, I see from Nate Vanendel, sincere thanks to Terry Botting and the rest of the CSO team who are supporting the deployment of staff. Also a huge thanks to those who have stepped up to take on a new call to support critical care. Absolutely.
Nice stuff. I see Dr. Stephen Kelly with his hand up. Go ahead, Stephen.
Yeah, Aaron, thank you. Yeah, I'd just like to maybe echo that the procedural task force coming together so quickly and getting the new sort of rules of engagement for what we're going to be able to do in the procedural areas, but also the teams that have been redeployed or are redeploying. And I mean, we appreciate their skills in the ORs and the procedural rooms every single day, and we're just very, very grateful that some of them are going to help for the critical care and just putting their efforts and their expertise into that area of care for our patients. So we just thank them for doing that.
Nice, thank you. I see Kelly Campbell, you have your hand up. Please go ahead.
Yeah, thanks, Aaron. I just wanted to shout out a big thank you to the teams that have been working on the mobile health unit planning. For those of the general site in the photo that Sharon showed today, the tents are actually going up, but the significant amount of planning work that goes into even getting ready to put the tents up is something that certainly needs to be acknowledged. So I just wanted to shout out to the facilities team led by Chuck Donahue and Daniela Pavlich. On the sports side, Anita Lamond. On the operations side, Rebecca Fleck and Jen Robinson, Carissa Corden, and then as well for capital, Teresa Reynolds and Jen Renuso. These folks have been working really hard all day, all weekend to get us to this point. Still lots more work to go, but on top of everything else they're managing, this is really a big ask. So thank you to them.
Nice, thank you. Leslie Coach, I see you have a hand up.
Yeah, so I need to echo Dr. Kelly's thanks to the peri-op teams. They are really a substantial piece of the plan to support the critical care expansion. So on behalf of both HHS and patients coming, sincere thanks. The other team that I really do want to acknowledge is all of our surgeons' offices, and they've had very challenging jobs in the last few days to be contacting patients who were scheduled for scheduled care. And informing those patients of the reason for their surgical postponement. And just that communication, that's a hard message for some patients and families to receive. And we often don't thank them enough. So just sincere thanks to the administrative assistants who are helping with that job.
Aaron, I see another shout out in the chat box from Linda Aliberti, who is saying a big thank you to the educators in critical care who very quickly created a process to support the redeployed staff into the ICU.
Nice. Well, Rob, I think I'll draw it to a close there and hand it over to you for final remarks. See everyone next week.
Yeah, so I'll be very brief, just given how busy everybody is. But as always, thanks very much. I know I say it every time, but it's because I mean it every time. Thanks very much to everybody who is working so hard to respond to this current situation. I know people are being asked to do unreasonable things, but we just don't have much choice, and people keep stepping up. So gee, I really hope this will be the last great push. I'm counting on it. So we just need to come together to get through it. And anyway, I'll just say thanks one more time and hope everybody has a good rest of the week, given all the circumstances. Cheers, everybody.